All right, so it looks like everybody's here. Let's call the meeting to order. And please stand with me and join in the Pledge of Allegiance. I pledge of allegiance
to the
flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. All right. D, roll call, please.
Director Yee,
Present.
Director Stewart,
Present.
Director Wallace,
Present.
Director Epen,
Present.
Director Nicholson.
Present.
Very good. Well, welcome to the February 9th, 2022 regular meeting of the Washington Township Healthcare District Board of Directors. To continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus, the Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Health Care Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the government code that quotes that quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Madam President, I make the motion that the board make the finding required by section 54953E3B2 of the government code that, quote, the state or local officials continue to impose or recommend measures to promote social distancing.
Thank you, Director Wallace. A second, please. Is that you, Dr. Stewart?
Yes.
Okay, thank you. Okay, D, roll call vote, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen,
Aye.
Director Nicholson.
Aye.
Very good. That motion passes. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Okay, moving on to communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement, not to exceed 3 minutes, on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none, Dee, are there any written communications?
There are not.
Very good. Then we will move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under action item. Under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No. Does any member of the public want to remove an agenda item from the consent calendar? All right, very good. May I have a motion to approve the consent calendar items A through C?
Yes, Madam President. In accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A through C.
Thank you. Is there a second?
Second.
Thank you, Dr. Stewart. Okay, roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Wallace,
Aye.
Director Nicholson.
Aye.
Very good. That motion passes. Thank you very much for working through all that. And we get to do the fun things now. Presentation. Kimberly, would you like to introduce our presenter, please?
Yes, thank you. It is my pleasure to introduce Dr. Sarah Wortman. She's a vascular surgeon here at Washington Hospital. She received her undergraduate degree from the University of California, Santa Cruz, majoring in molecular, cellular, and developmental biology. After earning her medical degree at George Washington University School of Medicine and Health Sciences, Dr. Wortman was accepted at the University of Southern California Department of Surgery as a general surgery resident. During her 6 years of residency, she served 1 year as a research fellow in USC's Division of Vascular Surgery and Endovascular Therapy. Dr. Wortman then completed a fellowship in vascular surgery at USC. While attending medical school, Dr. Wortman also worked as a research assistant with the GWU School of Public Health as a Robert Wood Johnson Foundation's Commission to Build a Healthier America. In the fall of 2017, Dr. Wortman joined the Washington Township Medical Foundation as a vascular surgeon and practices in the Washington Center for Wound Healing and Hyperbaric Medicine. She's had a lifelong interest in nutrition, health, and patient education. Although she specializes in vascular surgery, Dr. Wortman takes a broader view, looking at all aspects of patients' health. Factors such as nutrition, exercise, smoking, and diabetes all affect vascular health. So it's my pleasure to now turn it over to Dr. Wortman.
Hello, everybody. Can you hear me okay?
Yes.
Yes.
Okay, this is sort of a very comprehensive topic, so I'm going to try to do my best to summarize it for you all. Thank you for having me. I really appreciate the opportunity. So we're going to be talking about nutrition for health and a real food diet. So holistic is a term we use to describe therapies that attempt to treat the patient as a whole person. The idea is that the body's natural state is one of health, and illness or disease is an imbalance in the systems. So the food environment, toxic food environment can add stress to the already stressed systems, and stress will lead to inflammation. And we know that chronic inflammation can lead to chronic diseases. So when we talk about real food versus fad diets, so a lot of times discussions around eating healthy have to do with going on a diet. We say we change our diet, but we don't mean actually taking it. Remember that we don't eat individual nutrients, we eat whole food for our health. Oftentimes fad diets are about withholding and restricting rather than restructuring our diets. And they're generally unsustainable. They focus on a very small aspect of what it is that you're taking in your diet and not the bigger picture. Next slide. So real foods, they've been eaten for generations, thousands of years, obviously, and they're delicious. So it's really important to remember you can actually enjoy what you eat, and what you would expect to perhaps be quote unquote unhealthy might not actually be unhealthy. Next slide. So industrial foods are really the culprits behind the heart disease, diabetes, and other chronic illnesses. So foods that were created to solve our problem of cardiovascular disease are the foods that are now causing severe illness in our population. So these foods like margarine, refined oils, sugars, refined flours, skim milk. What had happened when we were looking at vascular disease in patients, we found cholesterol and fatty deposits in the blood vessels. And then we worked backwards from what we found, and we decided that we should say, well, people should remove these things from their diet because we're finding them in their blood vessels. Unfortunately, from the recommendations from years and years of low fat and low cholesterol diets backfired. It's resulting in unprecedented rates of metabolic syndrome, diabetes, cancer, and heart disease. And this industrial food system that I'm describing grew around a motive to replace these quote unquote bad foods with foods that met the official criteria of low cholesterol and low fat. But in order to make foods taste like something, when you remove fat and cholesterol from them, we end up adding sugar and artificial chemicals. Next slide. Thank you. So what are real foods? Real foods are vegetables and fruits. And you may have heard of a plant-based diet, but the terminology can be misleading. So obviously vegetables and fruits are essential in a very healthy diet. They're full of antioxidants and vitamins and minerals. Other plant foods include beans, legumes, nuts, and seeds. So a plant-based diet in like technical terms is not bad per se, but the idea has been co-opted by the industrial food system and is now more of a buzzword rather than a strategy for health. So plant-based, if you're saying you're having a plant-based diet, should mean that your whole diet is filled with plant foods like vegetables and fruit. It doesn't mean that a food item is derived from plant as an ingredient. So it's important to include these things in your diet, but include them as whole food items. Next slide. So what are some good options for vegetables and fruits? So red cabbage, blueberries, grapes, red peppers, they all have many antioxidants. And then onions, garlic, scallions, and leeks all contain allicin, which helps reduce damage to blood vessels and can help lower blood pressure, blood sugar, and cholesterol. Some studies have shown that the regular use of garlic in the diet can lower cholesterol as much as 8% and would translate to an almost 40% reduction in the risk of cardiovascular events for an average 50-year-old patient. Next slide. So when we talk about grains, so real foods in the diet regarding grains. So a whole grain, as you can see in this picture here, it's made of 3 parts. So it's the germ, the endosperm, and the bran. The germ contains the vitamins and minerals and the proteins and the oils, and the endosperm has the large inner part. Next slide. Which includes carbohydrates, proteins, and minerals. And then you have the bran, which includes the fiber and the B vitamins. So when you eat a whole grain, you're eating all of those things, which are all of the ingredients necessary for the health that you get, health benefit you get from those foods. So whole grains include oats, millet, quinoa, rye, and spelt. Next slide. How is this different from refined grains? So refined grains have been processed. Refining removes the vitamins, minerals, and fiber. And then for whatever reason, they add back the synthetic version of the nutrients that they've then removed. And the problem is that once things are removed and re-added, they're not as easily absorbed. And in this process, fiber is actually not added back to the grains. Next slide. So examples of refined grains are things made with white flour, pizzas, pastas, breads, rolls, pastries. And the thing about refined flour is it converts into glucose, which can quickly spike your blood sugar, which is bad for you. And digestion of carbohydrates requires B vitamins, and they can become depleted, and they've been removed from the grains in the refining process. Next slide. So real foods, as far as fats are concerned, so multiple studies have to date have been unable to find an association between dietary saturated fat and an increased risk of coronary heart disease or vascular disease. And it's been an ongoing sort of back and forth is how much fat is good, how much fat is bad, what kind of fat is good, what kind of fat is bad. And despite no real data supporting the evidence that saturated fats are truly bad for you when included in a comprehensive and healthy diet, there continue to be recommendations about limiting saturated fats. Next slide. So what are real fats? What are the things that include saturated fats that are good for you? So real fats are found in animal products like butter or other animal fats, tallow, duck fat, lard, ghee, olive oil, and omega-3s, which are a fatty acid that are important for health. They're found in fish, flax, walnuts, and grass-fed milk and meat. And fatty acids are important for a host of bodily functions, including proper brain and heart function. Next slide. So fat is required for the absorption of essential vitamins and nutrients, so vitamins A and D, lycopene, beta carotene, and these are powerful antioxidants that boost immunity and fight inflammatory conditions. And I keep coming back to this because really the problem with vascular and cardiovascular disease and all chronic illnesses is chronic inflammatory state. And important to note, the reason why saturated fats are necessary in these foods and in the diet is that they're required for the body to assimilate the omega-3 fatty acids, which are extremely important for overall health. Next slide. So the reason why all fats got, mixed in all of this, as I mentioned, they're found fatty deposits in the vessels, but we have unhealthy fats. And there's sort of this overlap between what's a good fat, what's a bad fat. So we know that trans fats and fats that are found in refined and processed vegetable oils like soybean, canola, margarine, that these are bad. These are inflammatory fats. And studies have demonstrated that trans fats cause arterial damage, elevate triglyceride levels, and raise the quote unquote bad cholesterol levels. And something that you might not know is that foods that are naturally filled with fat that have fat removed from them actually become inflammatory and unhealthy. So like low fat and fat-free products are not necessarily healthy. And that goes back to the kind of the thing I was talking about before about how when something, now that we say a heart healthy diet, we think low fat, low cholesterol, but those things actually can be inflammatory and actually unhealthy for people to be using. Next slide. So meat and dairy becomes a big thing that gets discussed when we talk about a healthy diet. And when people, the big push right now is for a plant-based diet, remove meat, remove dairy from your diet. And it's really very dependent on, I'm not quite there, you can go back a couple slides. And then one more, thank you, sorry. It's really dependent on the type of meat that you're eating. So cows are ruminants and they're meant to eat grass. And the problem is that next slide, in industrial feedlots, they eat grain. And when they eat grain, they get infections and bacteria in their gut and they require antibiotics. So then the grain is laced with antibiotics to prevent infection in the cows. And then this comes through in the milk and the meat that we eat. Next slide. So the quality of the fat in the meat or the dairy products depends on how the animals were raised. So pasture-raised animals roam freely in their natural environment and they eat grasses and other plants that their bodies are adapted to digest. And that allows them to develop into more nutritious sources of food. Next slide. Grass-fed meat contains 2 to 4 times the amount of omega-3 fatty acids and 4 times the amount of vitamin E than non-grass-fed meat. And they contain more conjugated linoleic acid and vitamins E, A, and beta carotene. So it's been estimated that only 40% of Americans consume an adequate supply of omega-3 fatty acids, and 20% have blood levels so low that they can't be detected. So actually switching the meat and dairy products that you eat to the grass-fed animals is one way to restore omega-3 fatty acids levels in your diet. Additionally, adequate levels of vitamin E, which are higher in grass-fed meat and dairy, is linked with a lower risk of heart disease and cancer, and it's a potent antioxidant that might have other really important health properties. And most Americans are deficient in vitamin E. So conjugated linoleic acid, this is another type of good fat, and grass-fed ruminants are very high in this, maybe one of the richest known sources of it, and it may be one of our most potent defenses against cancer. There was a Finnish study that showed that women who had the highest levels of conjugated linoleic acid in their diet had a 60% lower risk of breast cancer than those with the lowest levels. Next slide. So another really important thing to discuss that was really vilified in the low-fat, low-cholesterol diet is eggs, because they have very high levels of cholesterol. But eggs are essentially a self-contained whole food. So they literally provide all of the nutrients necessary to create life. That's what they are. And there are different categories of eggs sold, and it can become very confusing about what it is that you're buying and what the difference is and what it means. So, eggs are very rich in several nutrients that protect heart health, beta-ine and choline. They help lower homocysteine levels, which is an inflammatory marker. It can damage blood vessel walls, and choline is also found in the yolk. So you need to actually eat the yolk to get the benefit of the egg itself. So the options for cage-free, free-range, organic, and pasture-raised. So cage-free just means that chickens aren't kept in little tiny cages, but they can be kept in small spaces indoors. Free-range has a specific limitation to the amount of space they're given to roam. And then organic just means, are they raised with organic feed if they're being given feed in addition to being out on pasture? And then pasture raised means that they're left to roam free outdoors with, throughout the day on their own and eating whatever it is that's out there. So the pasture raised is what I eat and is what I recommend for people because the animals have a less stressful environment in their lives and they have a more varied diet, which allows for them to have higher amounts of nutrients in their eggs. Next slide. So fish, another important source of omega-3 fatty acids that we all know is fish. So omega-3 fats will raise HDL, reduce LDL and VLDL. So they increase your good cholesterol and lower your bad cholesterol. It also reduces blood pressure by dilating the blood vessels and reducing inflammation and triglycerides and reduce risk of clotting. They also have been shown to prevent against depression, anxiety, and help with memory. So when we talk about fish, wild caught fish tends to be higher in nutrients because they're in their natural environments. Again, there's a running theme here. It's free of artificial dyes, antibiotics, and grain feed. So I don't know if it's well known or not, but farm salmon, the flesh of the salmon is not pink. It's actually gray because they're not eating their natural food. So it's actually dyed red pink color to match the picture that you would expect from a wild caught salmon. And actually some farm raised fish are fed grains, which is obviously not in their diet. And best choices for these fish, wild caught, salmon, sardines, black cod, anchovies, and mackerel, they have very high levels of omega-3 fatty acids. And generally speaking, there's a lot of nutrients within the skin of the fish. So if you are eating it, it's helpful to eat that as well. Next slide. So what about beverages? So obviously plenty of fresh filtered water is vital. Aside from water, what I recommend to my patients and what I do myself is I really just have like water, coffee, and tea. So herbal teas are really good, green tea, moderate amounts of black tea and coffee in small to moderate amounts are okay. Not everybody tolerates coffee or caffeinated tea, so it's really, that's more of like a personal thing, but generally speaking, those things are not unhealthy to have, and sometimes they have been shown to be good for health. Eliminate, if there's one thing you do is eliminate sodas from your diet, and that includes sodas with sugar and without sugar. Any fruit juices are very high in sugar. Sometimes they have more sugar than sodas do. And then sweetened tea or coffee. So generally speaking, if you're having tea or coffee, you should have it unsweetened. And if you are going to sweeten it, use something that has very low glycemic index as far as sugars go, like honey. Next slide. So what about alcohol? Alcohol is basically all sugar once it enters your bloodstream. So excess sugar is stored in fat. So generally speaking, you just treat it as a treat, like a dessert. You have it on a special occasion because it's just like drinking juice or sodas. Next slide. So sweetening of food and beverages is often done with high fructose corn syrup. And fructose is found in high fructose corn syrup and in sugar that's added to foods, which is 50-50 glucose and fructose. It is a very common sugar substitute. It's found in sodas. Fructose is 2 times sweeter than glucose, and it is metabolized primarily by the liver, while glucose from sugar and starches like fruits and vegetables or bread, grains is metabolized by every cell in the body. So fructose intake is correlated with metabolic syndrome, elevated triglyceride levels, and cardiovascular disease, because if too much fructose floods the liver too fast, it's converted to fat, and then you end up with fatty liver disease. So just remember that industrial produced things like juices, breads, yogurts, ketchup, mayonnaise, salad dressing. So even your condiments have added sugar in them, and a lot of times they actually have high fructose corn syrup in them. And it's not really clear why those things would need sugar except to add flavor when you remove fat. Next slide. So it's really important to avoid refined sugar. So all candy, soda, cakes, pastry, sugary drinks, they should be avoided if at all possible. And then you really want to limit refined carbohydrates like white flour products, as I mentioned before, because a lot of that can be converted into sugar. Next slide. So your blood sugar, it's important to keep your blood sugar even throughout the day. So eating regular meals and snacks that are whole foods and refrain from foods that spike your blood sugar can really help. You don't really want really highs and lows in the blood sugar. And so natural sugars in moderation are best. So fresh fruit, raw honey, real maple syrup. So if you're sweetening foods for baking or for tea or for snacks, having like a jam that has no added sugar, is just berries, or putting a little bit of honey in your tea or coffee, or using maple syrup, a little bit goes a long way, and it doesn't spike your blood sugar as much as actual sugar does. And we know that uneven blood sugar leads to weight gain and diabetes. Additionally, elevated insulin levels, which will spike when your blood sugar spikes, are associated with increased cholesterol levels, triglycerides, blood pressure, and risk of cardiovascular death. I just want to mention in this at this point is that it's not about, and I keep saying this, that whole foods and fat are good for you, and it's not about calories. It's about the quality of the calories that you're eating. So, for example, like think about a sumo wrestler diet. So sumo wrestlers eat up to 7,000 calories a day, and they can weigh as much as 400 pounds, but they're not unhealthy. They have like low incidence of heart attack, strokes, or other symptoms of that we associate with obesity. So it's not really the amount of calories or even the fat that you carry on your body. It's where the fat is deposited in your body and the type of foods that are creating these problems for you. So the glycemic load of your food is what's important. And you balancing out the higher glycemic foods with the lower ones, like apple with cheese or whole grain toast with an egg, is really important. Next slide. So quality foods. So then that goes back to how much should you eat? Counting calories is not really helpful. If you're eating whole foods and healthy foods, then you'll be full from the foods that you eat. And you don't need to worry so much about how much you're eating. Calorie requirements are highly individualized, and it's really just important to focus on the quality of the food that you eat. Next slide. So as I mentioned before, vitamins and minerals are really important, and B vitamins are extremely important for your health, and people are deficient in B vitamins, but all of the foods that I've already previously mentioned, fish, meat, whole grains, vegetables, these all have high levels of B vitamins, folic acid, betaine, and choline. Next slide. So food stressors to avoid, foods that will cause increased inflammation and risk and increased cardiovascular risk. These are packaged, processed, and industrial foods, trans fats and refined fats, anything labeled fat-free or low fat or sugar-free that's not naturally without sugar, sodas and sugary drinks, high fructose corn syrup, refined grain and flour products, and added sugars. I tell patients, next slide, instead of looking at the list of calories and fat in the food on the back of the packaging, that you look at how much added sugar is in there and what the ingredients are. And if you don't know the names of the things in the ingredients, you shouldn't be eating it. A lot of preservatives and stuff like that, it's not good for you. So should people eat organic? That's one of the biggest questions that I get. Not all things labeled organic are created equal. Like I mentioned about plant-based diet, organic is another buzzword that's passed around a lot. And there is a whole industry created that defeats the purpose of organic food in the first place. The intention is to avoid chemicals and pesticides that are poison on fruits and vegetables and in meats and dairy, not to take refined grains, which will spike your blood sugar, and just remove the pesticides from them. It sort of defeats the purpose of a healthy food. So next slide, a study in the Annals of Internal Medicine showed overall that there was no nutritional benefit to organic versus non-organic foods. And they noted slightly higher, but they did note slightly higher phosphorus levels in many organic foods and higher omega-3 fatty acid content in organic milk and chicken, as I had mentioned before. Next slide. And organic produce had a 30% lower pesticide residue than conventional food. And in general, they said, well, pesticide levels were within allowable safety limits. But I guess my question to you and to everybody I talked to about it is, what kind of levels do you feel are allowable for you and your family to be taking things that are poison to living beings? Next slide. And that's really a personal question. And if there's not a statistically significant difference in the amount of nutrients in organic versus non-organic food, does it really matter? So if there are higher levels of nutrients and lower levels of pesticides, to me, that's worth it to be eating those foods that are organic. The problem is, next slide, is that organic is expensive. We don't really have a sustainable way for people who can't afford expensive foods to be buying organic. So I just here am presenting, just options for the things that are probably worse for you to eat not organic, and then the things that could be better for you to eat not organic. So for example, this is called the Dirty Dozen. These are foods that absorb the most pesticides when they're being grown. strawberries, spinach, kale, nectarines and apples, grapes and peaches, tomatoes, celery, potatoes, hot peppers. So these are things that you might think about perhaps buying organic exclusively. Next slide. Whereas these other foods, 15, may be safer to eat as conventionally grown rather than organic. And a lot of them, like avocado, pineapple, onions, peas, these things, they have skin that you removed. And so a lot of the pesticide has gone away. And the other ones, the cruciferous vegetables, don't seem to absorb them as much, and mushrooms as well. The only thing that I don't particularly like on here is corn. I don't really think that corn is the best food in general, and it's highly modified. So there's a lot of health benefit to non-organic corn. Next slide. So how do you actually incorporate all of the things that I've just said into your life? The problem is you want to take the stress out of what's for dinner every night. So you plan ahead, dinner, lunches weekly, and plan your shopping list weekly, and always have healthy snacks available. Then it becomes less stressful and easier. So you won't be grabbing things at the last minute when you're tired at the end of the day. And you can have something like an 80-20 rule, where if you're eating real whole foods 80% of the time, then every once in a while, if you have a snack or a dessert or some alcohol, it's not that bad for you. Your body is in general good health, and it's able to process these more toxic things without too much trouble. Next slide. So how do you eat best for your health? You eat whole foods, as I mentioned, organic fruits and vegetables, beans, legumes, pasture-based meats, dairy, eggs, and wild caught fish. Leafy greens, other non-starchy vegetables, cooking with real fats like butter, ghee, olive oil, and coconut oil. I tell patients that when they're cooking, you should cook with things that are solid at room temperature. So butter, ghee, animal fats, because they are stable at higher temperatures. The vegetable oils are oxidized at higher temperatures, and they're actually really inflammatory if you're cooking foods with them. And if you're cooking at like medium temperature in the oven or something, olive oil is a really good option. And just remember that I have just provided an explanation of the absolute ideal way to approach food. And unfortunately, the solutions that I provided are individual solutions, but this is actually a systemic problem. And people can't always afford these foods. Pastured meats are extremely expensive, and difficult to come by depending on where you live. And this is a systemic problem. And the true solution is to have a food system that provides people with affordable, whole, actual, real foods, and not really feeding them things that are toxic for their health. So we really just need to be eliminating the foods that make us sick and that kill us. Next slide. I think that's it. Thank you very much. Does anybody have any questions for me?
Yeah, I have a question.
Sure.
What can you comment on the role of fermented foods in a real food diet?
That's a great question, actually, and I didn't even bring it up in here, but fermented foods are extremely important for gut health. And because we have, generally speaking, industrial foods deplete our microbiome, eating fermented vegetables as like incorporated into your diet is actually really helpful, because it helps restore the gut microbiome. All of the antibiotics and the pesticides and everything that are found in industrial foods, they destroy the gut health. And then, when people are sick and they get an antibiotic for some reason, you end up completely destroying the microbiome and being susceptible to damage to the gut lining, which then can actually increase inflammation in the system. So fermented foods are extremely important. You just have to be a little bit careful, because fermented foods in too much quantity can cause stomach upset in some people. So you do need to incorporate them. Generally, I try to incorporate some fermented food into one meal a day as like a little side or a condiment type thing.
Great, thank you.
Yeah.
Thank you, Dr. Warman. There was a little bit of myth busting in there for me, especially with the eggs and the yolk and trying as someone with high cholesterol. So I appreciate your comments and a different way of looking at things.
Sure. And just one last thing I'll mention is that anecdotally, as a vascular surgeon, when I see patients who come in with stroke from a carotid plaque, 100% of the time they have a low HDL, and they don't always have a high LDL. So I think that and HDL is anti-inflammatory molecule, right? It's a scavenger. It goes and it fixes damage to the blood vessels. And we really had been focusing so much on lowering HDL and lowering LDL and not raising HDL. And really, if we've been, it's that like push for an anti-inflammatory diet and heart health makes a huge difference.
I have a question.
Sure.
Have you read the book Eat Right for Your Type?
I have
Do you know about this?
No.
Well, it basically says if you have certain blood types, you should only eat certain foods. Like a type A should never eat meat, for instance, and type O, they can eat all the meat they want. So I was just wondering if.
Yeah, I'm actually not sure about that, honestly. Yeah, there are a lot of
well,
good
one
books.
time.
Yeah, go ahead.
So one time I asked John Mahegan about this, and he said, I get an awful lot of heart patients that are type A, and and I was concerned about that because I'm a type A. So I said,
I don't think so. I will say, the thing about it is that people say, well, I never had, I never had to eat organic when I was a kid, and we didn't have to do local and pasture and all that stuff. But our food system didn't used to be the way it is now. Like even just 50 years ago, everything was local and everything was organic because we didn't have the pesticides we have now. We didn't have the industrial processing we have now. So it's just going back to how things were and just making sure we're seeing foods as nutrient and a whole food and not just something to, get through the day.
Okay, well, maybe I'll send you a copy of the book and you can tell me what you think.
I'll read it and I'll let you know what I think.
Yeah.
I think you're okay. I think it's just about moderation and balance and the type of meat that you're eating. Yeah.
Okay. Well, I don't like the whole thing because my wife is an O and she can eat all the meat she wants. And I'm an A and I'm not supposed to eat.
Meat can be inflammatory, especially if it's cooked at higher temperatures. So actually, like grilling meat on the barbecue is the worst thing to do with it because it's a higher oxidative stress to the meat. So actually marinating meats and stewing them is a way to reduce the oxidative stress of eating meat, and eating leafy green vegetables as a side, like a salad or sauteed spinach or kale, will reduce the inflammatory effect of the meat itself while you're eating it. So something to think of.
Yeah.
All right. Thank you.
Thank you. Great information for the beginning of the year.
Okay.
Any other questions or for Dr. Wortman before we let her go? Very good. Well, thank you for being with us tonight, for sharing your thoughts and experiences.
Thank you for having me. Have a great night.
Stay well. Very good. All right, let's move on with our reports now. Dr. Hyder, our Chief of Medical Staff, with your medical staff report.
Yeah.
Good evening.
Good evening to all. Thank you so much. So first of all, I want to highlight that our census continue to be high. Everybody is putting a lot of effort every day, from nursing to the medical staff, plus the the case managers, everybody, and it continued to be high, but we are under control. It fluctuates. A lot of SNP patients are there to be transferred, and that makes it a little bit difficult. And the other thing I want to thank, first of all, all the board members plus our CEO, Ms. Hart, and the administration for making it possible for the doctor's launch. And we moved day before yesterday, and it is so remodeled in such a nice way. And we are very grateful that it has been given an opportunity to use that. Everything is computers, everything is all very well done. The other thing I want to tell is the blood products. There is a nationwide shortage of blood. It's not acutely at this time, but in the future it could be. Right now, all the surgeries, everything, electives are all going on well. We do have enough supply at this time, but in the future it could be possible. There is always, due to the pandemic. And it's always encouraged to donate the blood. There is in Newark on Cedar and Maury, there is a center where we can always donate blood there. The other thing is all the active staff is vaccinated except one, which because of the reaction. So it's, that physician is exempted from the vaccination. Otherwise, all the active staff is vaccinated. Today, the census was 208, and in our census for the hospital medical staff is 571 with active 348 and allied 34, ambulatory 89, consulting are 8, courtesy 25, leave of absence 6, provisional active 47, provisional AHP 10, provisional consulting 1, provisional courtesy 2, and resignation is 1. So the grand total is about 571. And that's my report brief.
Thank you very much, Dr.
Thank you.
Thank you. Next up, Debbie Fury, our Service League President. Good evening.
Good evening. I want to thank the board and the volunteers. Want to thank everybody for all your help. The Service League began this year, 2022, in a typically busy fashion. During the month, 102 volunteers contributed 1,398 hours in all the volunteer areas. The request for volunteers to assemble the COVID-19 vaccine syringe kits came in strong during the month. Yes, we had an overwhelming ask and ended up coming in twice a week to make over 300 kits. And some of them are actually 2 kits in one. So, and since the Service League began assisting in the pharmacy with the labeling of the syringes back in early 2021, we've assembled almost 39,000 syringes. I'm also happy to report we have begun to see more interest in the community about volunteering with the Service League. And we held an orientation in January with 10 new volunteers. Some of them wanted to learn about our WOOF program, and the others are going into the nursing unit assist. And we're going to be holding our annual meeting on February 18th of this year, when new board members will be voted into office by the Service League members. We will also recognize volunteers for the number of years of service since they have contributed to the hospital. And we thank you all for all your support. And that's the end of my report.
Thank you.
Okay.
Nice that there are people stepping up, college and adults wanting to volunteer.
Yeah,
we can accommodate them.
Yes, we even have been interested also in doing the gift shop, which is now open 5 days a week, Monday through Thursday, and now we're open on Saturday. So we have the high schoolers doing Saturdays.
Oh.
So the high schoolers are slowly coming back since the lobby still isn't open, which is, for everybody's safety. But it's nice to see them in there, and they're doing a fantastic job.
Great. Wonderful. Thank you very much.
Thank you.
Thanks for being here.
Thanks.
Okay, we have a lean report next. Kimberly, can you please introduce there she is. Mintu's here.
Yes.
All right, well, I'll have you introduce Mintu. Thank you.
All right, and I also just want to thank Debbie and all the volunteers for all the work that they've done on the vaccine syringe kits. It's really helped us tremendously, and I know that Mintu is aware of that, and all of us with the testing and vaccine clinics. So thank you very much, Debbie, and all the volunteers for their help. Moving on, I would like to introduce Mintu Denon. She's the Director of Pharmacy. She's going to give us a lean report this evening. Mintu completed her undergraduate work at UC San Diego and received her doctorate degree in pharmacy at UC San Francisco in 1989. After graduation, Mintu moved back to San Diego, where her family resides, and started her career at the Naval Medical Center as a clinical pharmacist specializing in infectious disease. Mintu moved to the Bay Area and started at Washington in 1995 as a clinical pharmacy specialist. She assumed her current role as Director of Pharmacy in 1999. Thank you, Mintu, for joining us this evening.
Thank you, Kimberly. Thank you for letting me share with you a little bit about pharmacy today. So I wanted to talk a little bit about what we have been busy with in the second half of 2021, and focusing on medication inventory management. In the past, I've presented to you our clinical programs, but I think this is one of the first times I really talk about the inventory management, which is sort of like the foundation of pharmacy, right? We have to get the medications in and out, and we have to get have the medications be available when we need them. So a little bit about the background. What you see here is our Pyxis machines, and we have about 100 or so of these across within the hospital. There's 51 different locations, and you can look at it as sort of like a vending machine a little bit. Each one of those there's 3 components to it. There's the main, an aux, and a tower. The main is the one with the computer on top of it. It's stored about 140 meds. There are cubies inside of them, and the medications are stored in the cubies. So about 140 meds or so in each one of those. Total, we have over 7,000 pockets in all the mains that we have in the hospital. The next one is the auxiliary drawer. That's a 7-drawer. Inside it has little cubies. The totals are over about 6,000 pockets inside them, and we have about 37 of them in the hospital. The next one is the tower. The tower is for storage of the bigger medications. And you can have about 80 medications or so in that tower. And we have a total of over 1,000 bins. And then the picture I didn't have on here is the PASS, which is the anesthesia machines that we keep in the OR. And each one of those store about 160 medications. And we have 8 of them in the OR. So in total, there's about 16,000 pockets. And we have about 1,500 line items in all of these machines. We dispense about almost 2 million doses a year out of these machines, and which accounts for about 80%, a little bit over 80% of all the medications dispensed from the pharmacy comes out of these machines. So it's really important for us to keep the machines stocked, but we are also limited by the real estate. There's only so many pockets and there's only so much space. So on a daily basis, I have 2 pharmacy technicians that covers the main hospital and also pavilion, and they go and they fill these machines up. So there is a little bit of a trick to how often you want to access the pocket, how much you put on in there, and the par levels, the min and max of how much you store in these machines. Next slide, please. So one of our key goals for this year is, and we go back and refresh them every year is to improve patient safety and achieve financial improvements. And next slide, please. Given that is a key goal, how we improve patient safety, we want to make sure that we reduce stockouts. So these, the pockets, we have to maintain the par levels, min and max, and the par levels of each medications really range, really depends on, seasonal variations, the type of medications, whether it's low census, high census or not. It depends on, we don't want to put too much in there because each one of these medications have different expiration dates. So you want to minimize waste, but at the same time, you want to keep enough in there to have the medications when the patient needs them. So our goal is actually to keep just enough inventory in there. And what we had found is, when during a high census season, which is like last year, beginning of the year, with the COVID and everything, when you have high census, it really stretch what we do. It really taxed the system a lot. And what we were finding back in, beginning of the year is we had at the height of about 800 stockouts a month, which means every time the pocket goes to 0, we get notifications in the pharmacy to say, go up and fill that pocket. So we had about 800 of these a month, and that really disrupted the flow in the pharmacy. Every time you have to drop something to go up and fill the Pyxis. With that being said, what we wanted to do is we want to really focus on it. And our goal is by the end of 2022, we would get down to about less than 300 a month. It's really hard for us to ever get to zero because of national shortages, because of seasonal variations, because of, we can't anticipate what the use is going to be. So our goal is to get less than 300 by the end of the fiscal year 2022. So that's improving patient safety because we want to make sure that the medication is there when a nurse goes to the PICSs to obtain the medication, because if there's a delay there, they may forget to get it, or there is, the medication will be delivered late. Achieving financial management improvement. What that has to do with is it ties into the picture you see there, which is a med carousel. The med carousel is what we have within the pharmacy. It's a high density storage unit, and there's 27 shelves. And within those 27 shelves, there's rows of medications that we store. So one of the things we have to make sure is we have enough stock within the pharmacy to be able to pull it to stock the PICSs machine. So only about 50% of the medication stored in the pharmacy is in the med carousel. In my ideal world, I wanted 2 of those. And we actually did try to get 2 of them, but with the limited space we have in the pharmacy, we just could not get the second one in. Now in the new pharmacy, I will have 2 there. So the other half of the medications, for some of you have been in the pharmacy, is all over in the pharmacy. We have them on high density shelves, the shelving units. There's a back stock area that we fill up the med carousel when the inventory goes low or whatnot. So what we want to do is make sure we have enough stock in the med carousel or the inventory within the pharmacy to be able to fill the PICSs machines. So our goal there is 100% completion of counts. We have to count these. We have about 2,500 or so line items. So it's a manual count for us to make sure that we visualize each one of the medications on a monthly basis. And our goal is greater than 95% accuracy. We have to be really accurate in our count to make sure that we have enough medications. The par levels within the med carousel is what drives the purchasing. So once the par level drops down to a certain, that it drives our
Uh-oh. Did we lose her?
It looks like we might have lost her. Time's up.
Come back.
We're trying to reach her right now.
sorry, I'm sorry.
There you
my-
are.
about-
Okay.
Okay. So our goal is not greater than 95% accuracy. Next slide, please. So the key driver to this is to reduce the medication stockouts. We do monthly, we do an analysis of the whys. Why is there a stockout, and really look at those. Sometimes we have to change pocket size, or we have to move things around. So we want to look at the right sizing, review the cubic storage area, the accuracy of the cycle count. And on the other side, complete the accurate cycle count within the pharmacy. Some of our key drivers is it has to be done monthly. For one, we have to have standard process of performing this cycle count because it is a very manual process. And then all areas of the storage unit has to be evaluated and linked. So we have what I mentioned to you, we have the overstock areas. Well, the overstock areas have to be linked to what we keep in the med carousel. So because what happens when the text goes and count what's in the med carousel, not realizing that we have some in the overstock areas, then the total count will be off. So that process has to be linked. Or if we have something in the med carousel and something put aside to be unit dose, because now we have a national shortage and we can't get them unit dose, and it has to be manually unit dose, we have to link those two together. So there's some visual cues that we have to put in place to make this work. And then we have to address the process of what do you do with the stat? Because if a medication is just on the regular shelf, we have a critical med area where if the OR called down for a stat, then we just, sometimes the staff would just go grab the medications and run and deliver to the OR without going through the system to deduct the count. So we put some standard processes in place there. Next, please. So this is our performance work. It's updated in December. So the target condition for what our goal is to decrease the stock out. Our goal is to get down to about 300 by the end of the fiscal year, and to buy some of the stuff that we were doing and moving our meds around and increasing the QB size and all that. Some of the obstacles is very unpredictable. The census can be low today and high tomorrow. We just don't know. The usage pattern can be very, very unpredictable. There's limited space within the Pyxis med stations, like I had mentioned before. National drug shortages has been a big issue for us. Particularly this year. I mean, some of the things we were running out of is like, saline, sterile water for injections. I mean, some of the ridiculous stuff that we've never thought we'd be out of, resource allocations, and just a prospective review of, anticipating what's going to be a stock out and try and minimize that. Some of the system limitations I'll talk a little bit about too. So this have been our improvement project. We are focusing on it, trying to make sure we have our par levels, making sure we right size our QBs as needed. Some of the expected results. What we expect is, as we're adjusting the min-max level of it, that and anticipate some of the seasonal changes, that we can stay ahead enough so the pockets doesn't get down to zero. Some of the expected results would be to decrease the number of stockouts, and at the same time balancing, making sure that our meds are not in the Pyxis med stations too long to minimize sort of the outdates or the waste. The actual results I will share with you in our next slide. But some of the things I'm very excited about is we're in the process right now of implementing a software, because right now our process is very manual. We look back at the last 30 days and look out at the stockouts and try to minimize it. But with the implementation of the software and inventory management software, which should go live by June, the software actually integrates the Pyxis flow of how much is used in the Pyxis with the med carousel, how much we have in med carousel, and it will adjust the par level for us on real time instead of retrospectively. At real time, tomorrow, if it starts seeing certain medications being used a lot, it'll automatically adjust the par level for us. So when the techs come and fill the Pyxis, they would have a different par levels to fill. So that would be exciting for us. Next slide, please. So this is a graph of where we started at. So last year, January, February was very, very busy for us as the COVID hits its peak, and it really taxed our system that we have in place. So as you can see, during the high census months, we were at 924 Pyxis stocked out per month, and that is just a domino effect. We didn't have the medications in the Pyxis when it needs to, and down the pharmacy, it disrupted our workflow. So we started tackling this in May. Our baseline was around 600, 688 was our baseline. We started reviewing the reports. We started implementing some of the steps, and we continue our process there. We have a short-term goal and a long-term goal. Our short-term goal is we want to decrease that number by 5% every month. And long-term goal-wise, we wanted to maintain less than 300 stockouts a month. And that's what we've been trying to prove. So we were able to decrease by about 50% reduction or so within 5 months or so, which was great because the staff loves it. They're not, it doesn't disrupt their process as much. And as you can see in December and actually in January too, our stockouts has been around 300. We haven't quite made the 300 goal yet, but I think to put things in perspective, December and January are just really, really busy months for us with huge shortages that we're experiencing too. So compared to December and January of this year versus when we were really high census last year and we were up at 900, being at 300 or 400 is a significant improvement for us. So, and it's something we'll continue to work on. Next is our other project, which is the inventory. Completion of inventory within the pharmacy, within the med carousel. And our goal is to complete the inventory 100% every month. So, which means every month the techs are going through and counting every single tablet within the pharmacy. Now, until you visually look at the bin, you really don't know. You can't trust the system to keep track for you. So that is something that we work through. Our regular shifts, our night shift usually does that. Our techs on night shift works together, and they do it when they have the time to do it. So it's not like something that we set out a particular day, particular shift to do. So we try to do this on a monthly basis. On an annual basis, we do have an outside vendor that comes in and do our complete inventory, but we have to keep up to do a small piece at a time every month. And so our target is completion of monthly inventory, and our other target is accuracy of inventory. So our accuracy, we want to make sure we're greater than 95% accuracy by the end of the fiscal year. Some of the obstacles is really a resource constraint, because you physically have to look at every single pocket. And we have about 2,500 line items that they have to count. And the package size, some of them are unit dose, some of them are bulk items, the number of doses per package size, there's an overstock areas, there's a med shelf areas. So there's multiple areas within the pharmacy that that has to be counted manually. And then drug shortage and stock up. And so we have a whole section where we stock up on medications that are on national back order. So some of the improvement project is we automate the cycle count. And I can show that, ideally in the future, and this is another thing that I was interested in too, is coming this summer when we are going to be implementing that inventory system, it will automate the cycle count for us. Because right now, if you look at the next page, you can see it is very, it's this is just a process of the cycle count. Inaccurate inventory count is encountered when we have any stocking scenarios. We know that a physical inventory count is really difficult. It's just time consuming to do, and it is sort of a resetting the accuracy, and it's something we have to do more often than just annually, because our inventory within the pharmacy has to be accurate in order for us to have medications available for the Pyxis fill. The problem with this, the inventory is a huge undertaking. And that's why we decided to split it up into small chunks. In 2021, we had actually adopted, we've always done cycle count, but we never really look at the accuracy of our cycle count. And we ran out of some critical meds. So we went back and said, okay, we need to look at the accuracy of our cycle count. And we had to adopt some techniques in how to do this. Next, please. This is the manual tracking of what I was referring to. And if you look on the left-hand side, it's a table. There are 7 shelves in the med carousel. That's only 50% of the medications we have in stock. So what the techs have to do is they go through, and when they finish a shelf, they sign off of it. Finish the next shelf, they sign off. This only accounts for the medications in the med carousel and the ones on the remote shelf. It does not account for the medications that's stored in the IV room and the refrigerator. So there's another sheet there too. And then we run the reports. So they do the physical count, they enter the count into the system, then we run a report to see, our completion rate. Next slide. So here's our cycle count compliance. When we started this in July of last year, they were able to complete about 88% of the time. And keep in mind that we have close to 2,000 or so line items, and 8% of the times where they were able to complete it. As of December, we were up to 99.7% of the time. So it has been a huge completion rate. The techs have done an excellent job. We have moved and fine-tuned some of the systems to improve some of our systems so that they are able to get more cycle count completed. Next slide. The next thing we also look at is, accuracy. So now that you complete the count, how accurate are we? So we started out last July at about 85% accurate. Our goal is to be close to 95% accurate. And you can see there, we have a little gap there to go. We've been maintaining about 82, in the 80s or so, but keep in mind too, that before we were completing about 88% of the cycle count. Now we're up to 100%, 99.7%, which is 100%, which means more medications are being counted. And we're still, at around 82% in December. They are counting a lot more. We're getting a lot more accurate in our count. As if you look at the raw numbers, about 1,500 medications or so in December were counted. They were accurate, and this accounts for if one aspirin is off, is inaccurate. It has to be 100% accurate to be considered accurate. There's no gray zone. There's no fudge factors. One off is one off. Is how we count. Next slide, please. So before I go on to lessons learned, one of the things that I'm excited about when implementing the new system is that we at that point can assign how often we do the cycle count at the individual drug level, because there's certain medications we want to make sure we always have in stock. So those medications, or the critical care meds per se, we want to make sure we count those on a weekly basis. Whereas, low use medications, we want to make sure that we count those on a monthly basis. So now we can assign how often the medications will be counted, and it will automatically populate into the text work queue on a daily basis to say, okay, these are the medications you need to count today. And the system then will track for you how much you have, and that work queue will not go away until you complete that count. So it's an automated process I'm looking for, that on top of the par level automation, as it integrates between the Pyxis med stations on the floor, the med carousel in the pharmacy, and then the purchasing, sort of like letting us know which medications we need to order and put out a PO or a purchase order for us. All that will be all tied together with our new inventory management system that we're going to be implementing this summer. So some of the lessons learned, it's really important to have an active inventory management system. That's how we minimize the risk of running out of medications when we need it. We want to maximize the use of technology to drive efficiency. Integration is really the key. We picked the system that we picked because of the integrations between the Pyxis med stations, the med carousel, and also our McKesson purchasing. We have to systematically address disruption to workflow by understanding whys. So we went to the Gamba, we talked to text, and we try to figure why are we off, and try to link all those different sites together and manage proactively, not reactively. So when we get to the point we can manage proactively, we can drive our numbers down a lot more. And the last thing is, utilize your resource, engage in the staff. The staff is what really drives this program. I mean, they're coming to us because they see that we're working on it and we're focusing on it. So it's really the great staff that I have that makes the system works. And the last quote there: the only mistakes in life is the lessons not learned, and we're continually learning. Thank you for letting me share a little bit about pharmacy today.
Thank you, Mintu. It's overwhelming to think about the millions of pills that are that you have to keep track of, all of that medication.
Mm-hmm.
So thank you. I'm glad you're getting some automated help.
Yeah.
Great. Any questions for Mintu? Well, thank you for being here tonight.
Thank you.
You have a great team. You do. Very good. Okay, well, I'll move on to our next quality report. Kimberly, want to introduce Dr. An?
Yes, thank you. I'd like to introduce Dr. Jeannie An. She's the Medical Director of Acute Dialysis Services. Dr. An has been a community nephrologist in Fremont since 2001. She is the Medical Director of Washington Hospital's Acute Dialysis Services and is also Medical Director of DaVita Fremont Dialysis Unit. She went to college at UC Berkeley and graduated from the University of Illinois at Chicago School of Medicine. She completed her residency at Kaiser Permanente in Oakland and her fellowship at UC Davis in Sacramento. Dr. An is married with a daughter and 2 rabbits. Thank you for joining us this evening, Dr. An.
Hi, thank you, everybody. So I'm going to tell you about our acute dialysis service. This is what happens to all those people that fail to follow the dietary advice that you heard earlier from Dr. Wortman. They end up on dialysis and come here and get to meet me. So next slide. A little overview of our dialysis unit. Our service has been outsourced and internalized several times. In 2018, we internalized our dialysis service. We offer the modalities of hemodialysis, peritoneal dialysis, and plasmapheresis. We're currently located in a 4-bed unit on 3 South. After maybe 19 years of working, we finally completed the remodeling of 3 South, and it's very nice now for the patients and also our staff. We finally got rid of the 70-pound CRT TVs that were hanging on our walls, and we have space for family to accompany the patient, although because of COVID, really nobody's been accompanying the patients there. We also do bedside treatments in the ICU and in the COVID rooms. We are open for dialysis service 24 hours a day, 6 days a week. So on Sundays, we're on on-call basis only. We don't have a regularly scheduled treatment. Next slide. So, what is it? What service is it that we provide? What is dialysis? So this is sort of a cartoon that tells you about the 2 main modalities of dialysis. That dialysis is a process by which waste products such as toxins, extra salt, extra water are removed from the body. It helps to maintain normal levels of certain chemicals in your body, such as sodium, potassium, bicarbonate. This is what your kidneys do for you. They maintain equilibrium for every cell in your body. They're the most important organs in your body. Sorry, Dr. Nicholson. And dialysis is like a replacement for those functions. So who is it that needs our dialysis services? They're patients with acute kidney failure from overwhelming infection. And recently we have seen that with our COVID sepsis patients, from trauma or other sudden catastrophic health events. In addition, we have our chronic dialysis patients. These are patients who don't have kidney function due to progressive, irreversible loss of function from diabetes, high blood pressure, other chronic illnesses, including not eating well. Next slide. Hemodialysis is our most commonly used form of treatment. This is when blood is passed through a filter to remove waste products and extra fluid. And generally it's done through a catheter that's inserted into a large vein or from an artificially created vein in the patient's arm. And this is a schematic of what that looks like with the hemodialysis machine at the bedside. Next slide. So peritoneal dialysis accomplishes the same thing. This is when toxins are removed from the body through a tube in the abdominal space. So we place clean dialysate, clean fluid into the abdomen. The toxins filter into the fluid in the abdomen, and then it's drained out of the body and replaced with clean dialysate. And in that way, your toxins are removed from the body. Next slide. Our nurses also provide a service called plasmapheresis. So plasmapheresis is a method of removing blood plasma from the body by removing the blood, putting it through a centrifuge to separate the plasma from the cells. And we transfuse the cells back to the patient, but remove the plasma fluid. So plasmapheresis is used to treat conditions in which a protein in the plasma, such as immunoglobulin, is toxic to the body. So many conditions, including neurologic, such as Guillain-Barré, hematologic, like TTP, metabolic, rheumatologic, and kidney diseases, as well as intoxications, can be treated with plasmapheresis. So not all hospitals offer plasmapheresis, and we're very proud of the fact that all of our nurses are cross-trained in all of these modalities. Next slide. Okay, so these are the continuous quality improvement measures for fiscal year 2021. These process indicators include patient education. So when patients are on dialysis, this is a good time for the nurses to approach them with dialysis education, including diet, access care, fluid management, and a variety of topics. Patient identification is always important. We take our infection control very seriously. So our process quality measures also include compliance with bacterial endotoxin, chloramine water testing, infection prevention, including hepatitis B status, hand hygiene. And one of our goals is to be able to measure the patient experience for our dialysis unit. Next slide. Okay, so utilization. These are our counts. As you can see, the predominant form of therapy at the hospital is hemodialysis. That's the bar in the orange. Our second most common treatments are CAPD, which is the peritoneal dialysis. And then we have a few cases of plasmapheresis as the conditions that are used that require treatment with plasmapheresis don't occur as often as our other modalities are used. Next slide. Patient safety measures include timeout documentation, hepatitis B status. We monitor the number of rapid responses and code blues during dialysis, and infection prevention measures, including our water culture and hand hygiene, PPE. Those are all quality measures that are monitored. Next slide. So our timeout documentation was revised to be specific to dialysis. It includes issues like their hepatitis B status, and includes verification of the RO and dialysis machine log for cleaning of the machine, as well as a place where we can document MRSA swab being completed or not. Next, you can see we don't have a problem with our monthly timeout documentation. It's it's 100% most of the time. Next slide. Hepatitis B status unknown. This has improved a lot. This in part, this is because our lab has offered more rapid turnaround time. So our Hep B status unknown has dropped to below 1%. So over 99% of our patients that are dialyzed have a known Hep B status. This impacts how we clean their machine. And because bloodborne illness is always a consideration when you're doing hemodialysis, this is something that we regularly make sure we have charted on the patient's record. Next slide. This is an example of what our water culture and endotoxin reporting looks like. This is done on a monthly basis. And since we've taken over the service, we've not had any major problems with water culture or endotoxin fallouts. Next slide. Infection control. This is data provided to us by the hospital. This goes to third quarter, and our hand hygiene in the hospital has been, for the dialysis unit, has been 88, 92%. Our goal is obviously 100%, and we'll continue to work on that. Next slide. So one of our performance improvement plans for the year included patient education. We wanted to standardize the patient education materials and improve the documentation of what we were actually sharing with the patients. So in order to do this, we asked Epic to create the options for documentation, and we created a certain set number of topics so that we know when we say we educated the patient, exactly what that means. Improving the documentation allows us to also track which patients are unable or unsuitable to be educated. That way we can see that if the fallouts were because the nurses didn't take that opportunity or because the patient factors precluded them from being educated. So we have a monthly review of these quality measures, including our patient education statistics, and we offer feedback to our nursing staff. Next slide. So our post-procedure patient education percentage, our goal is 100%, and we're in the low to mid 90s at this time. This data, it was up until June. I think our improved documentation process was done in the fall. So I think that for the rest of 2021, we should see an improvement in that number from where it currently is, although our current numbers aren't bad. Next slide. So CLABSI was another area of improvement because many of our patients dialyze with catheters, including patients that start in the hospital. Line infections is a topic of interest to us. In order to improve our CLABSI infection control, we had instituted a trial of ClearGuard antimicrobial caps. So these are the caps that are on the tunneled catheters that the dialysis patients use. So they're infused with citrate, but the caps typically had just been regular plastic caps. The ClearGuard caps have an antibacterial substance impregnated in them, and they are more expensive than just regular catheter caps. I believe we started this a month or two ago, and we are looking to see if this impacts our rate of catheter line infections. So again, the line infections are monitored monthly, and the new thing that's happened is that this year, infection control was able to separate out from all of the line infections in the hospital, which one were related to dialysis catheters or not, so that we can specifically see how our performance is. Next slide. Okay, so when we asked them for the data, they give us like all the data. So they went back to 2018 and separated out which CLABSIs were related to dialysis or not. To me, it looks like it varies between 1 or 2 infections per quarter. And the statistician put that line there that says that we're getting better, that the the inclination is lower. I hope that that's true. And this data goes to quarter ending September 2021. But now at last we have a way of following our progress in terms of how our dialysis population is contributing to the hospital's overall CLABSI infections. Next slide. Okay, so continuous learning is always a goal in terms of general education. Our staff has completed 100% of our staff has completed their training on plasmapheresis and peritoneal dialysis, so they can be fluent in all modalities. They have an annual dialysis specific skills validation that our assistant nurse manager, Kirk Kaufman, helps to perform for COVID-19. They're validated in the use of the personal protective equipment, and there was a physician in service given by me on a common dialysis emergency. Next slide. Quality blueprint for fiscal year 2022. So these also include patient, this is similar to the slide that you saw earlier. It includes patient education, includes procedure timeout, compliance with bacterial and chloramine water testing, hand hygiene, and a new blurb on here is the stat treatment completion. The number of stat treatments since we started our internalized service has dropped dramatically. So we don't have a lot of stat treatments, but Completing the stat treatments, and that means within a 2-hour window, has been challenging because of some logistical factors. For example, patients are not given rooms until they have a COVID status, or the patients need to be in the ICU or IMC before our treatments can start. If they're assigned to a floor, then they're allowed to go to 3 South so we can do their dialysis quickly. But because the entire workflow is a little different than before we had COVID, and also because the hospital census has been so high and it takes so much longer for patients to actually get to their room or be assigned to a room, it takes, those are things that need to be in place before we can dialyze them. And that impacts our ability to meet that 2-hour window. Next slide. Patient outcomes, quality blueprint. Quality measures include adverse event rate. Those are the code blue or rapid response rates. Complications, including hypotensive events, infection, such as the line infections we talked about, that's the bloodstream infection. Patient experience, we're hoping to have a way to capture that, and infection prevention. Next slide. Our accomplishments, we had a successful Joint Commission and Magnet survey. One of our special responsibilities is that the dialysis population was chosen for screening of MRSA on admission and at discharge. So we had struggled with that previously, but now that we have a night nurse and other procedures that are in place, including kind of reminders on Epic, we have had much improved MRSA swab compliance for our dialysis patients. Because our nurses are available 24 hours a day, that's contributed to the reduction of actual stat treatment that needs to be ordered. During the COVID-19 pandemic, the hospital has done a lot to give the staff the perception of feeling prepared, safe, and well cared for. We implemented some policies for our dialysis staff when the census gets too high, in order to make sure that the patients are all cared for, but that our staff were not working 18-hour days. Our timeout process was improved. This was done in 2020. We have a Snapboard scheduling process in place. This allows the nurses on the floor to see when the patient's dialysis schedules are planned, so that they can avoid conflicts with ultrasound, Whirlpool, other procedures. We have new policies for improved mobilization to avoid treatment in hospital beds, to increase the number of patients that are moved to the recliner chairs, for example. And as I stated before, policies during high census to avoid staff burnout. In addition, our patients are able to be monitored remotely. Our telemetry patients can be monitored remotely through the Philips system. Next slide. Next steps. So our dialysis patients have a lot of social needs: transportation, clinic placement. Clinic placement during the COVID crisis has been an issue. Medication coverage, sometimes their insurances don't cover the antibiotics, the binders, the multiple number of medications they need. Housing issues and mental health needs. Those are all issues that we ask our medical social workers and discharge planners to help with when the patients come to the hospital. During surges, COVID planning is for placement in our outpatient dialysis units, and also for placement in the community rehab centers is something that has been an important part of their care when they're admitted. Community outreach, This was something I discussed with Larry also, is that although this is a dialysis service, we also want to educate the public about chronic kidney disease, the factors that lead to chronic kidney disease, how to be aware of how their kidney health is, to avoid them ever reaching the place where they need to have dialysis in the first place. So, prior to COVID, we did have, Dr. Umema had coordinated World Kidney Day, and we had done seminars for the public and things like that. So it is a little bit trickier, but maybe that's something that we can do again, because I think that it's an important message that we should tell the community about in terms of their health. Next slide. I think that's it. I don't have a thank you slide, but thank you very much for taking the time to listen to presentation. Do you have any questions? No, I did. I have answered all your questions. You're just amazed at the wealth of information received.
I would just like to make a comment. First of all, thank you for your leadership of the program. The dialysis team, for the board's awareness, has been incredibly busy, like everybody else has been over the past, since Christmas. And one of the things that's been unique over the past month, I think Dr. Ahn mentioned this a minute ago, was really that we've got people in our community that are testing COVID positive, and they've had limited access to dialysis chairs in the community. So our ED has been coordinating with case management and the dialysis team to bring these community members back into our hospital here through our ED and through scheduled appointments to bring these folks back in so they can get their needed dialysis treatments, to keep them out of our ICUs and to keep them healthy. So there's been several patients that we've brought in over the past 5 or 6 weeks in particular that have had limited access to chairs in the community that we've dialyzed here that typically wouldn't be coming into our hospital. So there's been a lot of people involved in the coordination of care, including Dr. Ahn and the dialysis team and case management and the nursing team. She also mentioned the ClearGuard caps. This is a really big thing for the dialysis catheters. What we learned about our CLAPSIs over the last 3 years is that 54% of all of our CLAPSIs were related to dialysis catheters. This is a very high-risk group of patients that are coming through. And these ClearGuards, now they are pretty new to being used, as Dr. Ahn mentioned, so we know what the research has shown with ClearGuards in other hospitals. We haven't seen any CLAPSIs since we started using them, but the team has sponsored them. We've got them purchased, and they're available for every dialysis catheter now when we send people over for hemodialysis. So these are in use, but thank you, Dr. Ahn.
Great.
Welcome.
Thank you for that input, Larry, for giving us that insight to the challenges and for the way that you are being there for the residents of our district during this very challenging time. You're saving lives there, and we thank you for being available, for being innovative and flexible, making it happen. Thank you. Great. Thank you so much. Any other questions for Dr. Ahn from the board? Or great. Well, keep up the good work. Thank you. Have a good evening.
Thank you.
Great. It's always so good to hear what's going on in the different areas. All right, let's move on and hear from Chris Henry, our VP and CFO, Finance Report for December.
Okay. There it is. Okay, as Director Yee said, we'll be looking at Washington hospitals operating and financial results for December 2021. Inpatient average daily census for the month came in 15.5 higher than budget at 150.1. When we add in patients that were in beds for observation but have not been admitted as inpatients, we end up with a combined average daily census of 161. That's 19.1 higher than what we had expected in the budget. Admissions for the month were 56 higher than budget at 856. Our patient days likewise were higher by 482 days at 4,654. Outpatient observation days for the month came in 110 higher than budget at 337, and our average length of stay came in at 5.4, pretty close to the budget of 5.22, about 1.18 higher. Looking at utilization, the case mix index in December was lower than budget at 1.499. That changes in January. It will go up. Deliveries for the month were 2 below budget at 137. We had 397 surgical cases for the month. That's 59 higher than what we had expected. Cath Lab cases likewise were above budget by 31 at 203. Outpatient visits for the month, about 64 higher than budget at 7,303. And our emergency room continued to be very busy with 4,817 visits. That's 926 higher than what we had anticipated in the budget. Looking at our surgical and cath lab volume, in the surgery area, really joint replacement cases driving the majority of the variance there. We did expect in the budget that Peninsula Surgery Center would be open at this point, and some of the joint cases would be migrating across the bay. That has not happened yet, so we're doing those procedures here. Neurosurgical cases were also higher than budget by 4, and then cardiac surgical cases and other surgical cases below budget by 5 and 3 respectively. In the cath lab, non-vascular interventional radiology procedures really drove that variance. Neurointerventional radiology procedures were right on budget, and peripheral vascular and cardiac visits were both 6 below budget, respectively. Moving into productivity, our productive FTEs for the month, as you would expect, with the activity 115.4 higher than budget at 1,346.4. We had 203.3 non-productive FTEs in the month. That was 26.6 lower than budget, so we end up with total FTEs that were 88.8 higher than budget at 1,549.7. Our FTEs per adjusted occupied bed, which is our productivity measure, came in lower than budget at 5.81. We had anticipated 7.13 in the budget, and I think that's reflective of some of the staffing issues we've been seeing over the past several months. Moving into the financials, total patient revenue for the month came in almost $21.6 million higher than budget at $193,496,000. Our deductions from revenue for our contractuals came in lower than budget at 76.85. We'd expected 77.16. Looking at the details of our contractuals, we did have a favorable payer mix. Our contractual allowances, which include our government and commercial payers, came in at 74.88% of gross revenue against a budget of 75.27. Our provision for bad debt, our private pay for the month was closer to budget than we've seen it in a while, at 2%. So our provision for bad debt and charity came in a little higher than expected at $3.8 million against a budget of $3.2 million. So our total deductions for the month came in about 12.1% higher than budget, following along with that revenue at $148,703,000. So we end the month of December with net operating revenue of $5.5 million higher than budget at $45,173,000. Operating expenses for the month came in just under $2 million higher than budget at $42,791,000. a good chunk of that being driven by salaries and wages with our higher FTEs. Our benefits for the month were actually lower than budget by $504,000, largely driven by our health and welfare claims in the month, and our employer taxes were a little bit lower than we expected. Supplies were above budget by $660,000, driven by prosthesis with our higher level of joint procedures, general medical supplies and gloves and disposable gowns also higher than budget, driving that variance. Our pro fees and purchase services were $541,000 higher than budget, driven by consulting. We have two things going on in consulting. One is the clinical intelligence engagement that we've been talking about, and also Trifecta, both of them working on things related to rev cycle and case management and billing and collections. Insurance, utilities, and other were $81,000 lower than budget, driven by marketing and software maintenance costs. So we end December with a operating income that was almost $3.6 million higher than budget at $2,382,000. We had expected a loss for December of almost $1.2 million. Non-operating income for the month came in $668 lower than budget, showing a non-operating loss of $582,000. The majority of that driven by a $455,000 unrealized loss on our investments. So we end up the month of December with a total bottom line of just right on the $1.8 million. That's $2,898,000 higher than what we expected in the budget for the month. Take a quick look at our Financial Accounting Standards Board presentation. This includes adjustments that the financial markets might make to our Governmental Accounting Standards Board format that we just looked at. First thing we do is we reclassify the interest expense on our revenue bonds of about $575,000 in the month out of non-operating and up into operating expenses to end up with operating expenses from a FASB perspective of $43,366,000 and operating income of $1,807,000, about almost $3.6 million higher than budget. The next thing we do in the non-operating area is we eliminate the interest expense and the tax revenue that supports our GO bond debt service. And then we pull out that $455,000 unrealized loss on our investments. FASB does not recognize those transactions to end up with non-operating income from a FASB perspective of $164,000 and total net income of $1,971,000, a little more than $3.3 million higher than budget. Quick look at our earnings before interest, taxes, depreciation, and amortization. This is an estimate of how much cash the operations are driving. We look at our operating expenses before depreciation expense, which is a non-cash accounting entry, to come up with operating expenses for EBITDA purposes of $38,905,000, and our earnings before interest, taxes, depreciation, and amortization from operations of $6,268,000. That's $3,562,000 higher than expected in the budget. The next thing is we go down to non-operating income and we separate our interest expense in that classification. So we end up with other non-operating income of $1,150,000. So in total, Washington Hospital's operating and non-operating activities generated about $7.4 million in the month to service our debt and to provide funds for capital expenditures, development of new programs, and any number of other activities. So are there any questions on December's results? Pretty good month overall.
Mhm.
Okay.
All right, then I will move forward with the operations report for January. And I think you'll see that January was a very, very busy month for us, and we also had a very high COVID volume too. So you'll see those two factors in the statistics. So beginning with gross revenue of $209.1 million for January was above budget by $29.5 million and above January of 2021 by $24 million. Inpatient gross revenue of $129.7 million was above budget by $12.1 million, but $1.2 million below January of 2021. And I think just to remember, despite the shift in joint replacement cases from inpatient to outpatient, we still had higher admissions in the inpatient side than was budgeted. So outpatient gross revenue of $79.4 million was above budget by $17.5 million and $25.2 million above January of 2021. So even though it was a busy month, we continued to do procedures and surgeries and other that you will see coming up. So in January, we should note that we had 191 COVID-19 discharges, representing 22% of total discharges. This is 6 COVID-19 cases less than the peak in January of 2021 at 197 discharges, representing 25% of the total discharges. Very similar to what we experienced last January. Going on to key census statistics, average length of stay of 5.51 was above the budget of 5.17 by 0.34, but lower than January of 2021 length of stay of 7.49 by 1.98. The average length of stay for the 191 COVID-19 patients discharged in January was 6.09. Although it was still higher than the average that we had seen overall for COVID patients, which was about 8.96. I think the difference, this reflects the lower acuity of the more recent COVID-19 cases that we saw during this recent surge. And also, I have to say, it's the improvement in the coordination and transition of care that we've been working on too. Going on to outpatient observation days, we're 48 above budget at 271 days, and we're 92 above January of 2021. Inpatient average daily census of 178.7 was above the budget of 142.4 by 36.3, but was 2.6 below January of 2021. Then looking at our combined average daily census of 187.4 was above the budget of 37 by 37.8 and was consistent with January of 2021, so very close. In January, there were 4 discharges with length of stay greater than 30 days, ranging from 38 to 86. I do want to just say, still in-house at the end of the month, we have 11 patients with length of stay over 30 days, and they range anywhere from 32 up to 252 days.
Wow.
So we still, yes. Moving on to admissions. Admissions were above budget by 41 or 4.8%. And admissions for the month were 105 or 13.3% above January of 2021. Admissions, moving on to patient days, admissions were above budget by 4.8%, and average length of stay was higher than budget by 6.6%, which resulted in patient days of 5,539 and was above the budget by 1,125 or 25.5%. You can see that patient days for the month were 81 below January of 2021. Looking at our surgical trend, total surgeries in January of 406 were above the budget by 45 or 12.5%, and surgeries were 120 above January of 2021. Inpatient surgeries at 147 were 6 below budget, but 25 above January of 2021. And outpatient surgeries at 259 were 51 above budget and 95 above January of 2021. I think, as Chris mentioned, we continue to, the Peninsula Surgery Center has not yet, we're open. We're waiting for the accreditation process that will hopefully happen in the next couple of months. It's all been delayed given the recent COVID surge, and so we're waiting for that to happen. And that is one of the reasons why our joint cases you will see are over budget. Moving on to surgical activity, our joint replacement surgery cases were above budget by 58 or 40.6% and were 84 above January of 2021. Neurosurgical cases were above budget by 12 and were 12 above January of 2021. Our cardiac surgical cases were above budget by 1 and were 4 above January of 2021. And lastly, all other surgical cases combined were below budget by 26, but were 20 above January of 2021. Looking at our Cath Lab trends, Cath Lab cases for January at 171 were 21 below budget, but 2 above January of 2021. Our Cath Lab inpatient cases at 105 were 2 above budget and 8 above January of 2021. And then Cath Lab outpatient cases at 66 were 23 below budget and 6 below January of 2021. So we saw a lower Cath Lab volume. Looking at the breakdown, cardiac cases were below budget by 24, but 5 above January of 2021. Our non-vascular interventional radiology cases were above budget by 9 and 9 above January of 2021. Our peripheral vascular cases were below budget by 11 and 13 below January of 2021. Our neurointerventional radiology cases were above budget by 5, but 1 below January of 2021. I do want to say recently one of our vascular surgeons has left, and so that is contributing to the lower number in our peripheral vascular cases. Moving on to deliveries. Deliveries for January of 114 were above budget by 9, and deliveries were 23 above January of 2021. Looking at our non-ER outpatient trends, our non-emergency outpatient visits of 6,944 were below budget by 559 visits, but were above January of 2021 by 373. Our lab visits at 2,564 were below budget by 18% and 9.4% below the prior year. Our X-ray visits at 1,549 were below budget by 7.2%, but 12.9% above the prior year. And our cardiac rehab visits were above budget by 31.7% and 52.9% above the prior year. But we're still working on increasing that volume up to a pre-COVID levels. Looking at our emergency room visits, we hit some very high numbers this month in January. Emergency room visits of 5,154 were above budget by 1,181 or 29.7%, and 1,442 or 38.8% above the prior year. There were 803 COVID ER visits for the month. Emergency room visits excluding COVID visits were 4,351. This was above the budget by 378 and 639 above prior year. I do want to just say that January had the highest month of visits at 5,154 since 2015. And we also had the highest day of visits, which was January 3rd with 241 visits. So our emergency room was very busy during the month of January. And I have to just say that the whole emergency room team there, including ancillaries and EVS, everyone really pulled together and worked well to ensure that our patients were able to get the care they needed. So I know it was very busy there, along with throughout the house, but especially within the emergency room. Moving on to gross revenue. As mentioned, Cath Lab cases were below budget by 21 or 10.9%, and high dollar cardiac cases were down, resulting in revenue being down by 1.9 million or 15%. Deliveries were above budget by 8.6%, driving revenue up by 12.8%, or 370,000. We also had C-sections that we had 40 C-sections, which were above the budget of 37 by 3 cases. Our emergency visits were above budget, as we know, by 29.7%, driving emergency revenue up by 3 million or 27.9%. Our patient days were above budget by 25.5%. However, there was a lower utilization of ICU care, driving room and board revenue up only by 20% or 7 million. Our total surgeries were higher than budget by 12.5%. There were more neuro and cardiac cases, as mentioned, driving surgical services revenue higher than budget by 28.6% or 9.4 million. And lastly, inpatient and outpatient activity drove ancillary services revenue above budget by 11.8 million or 13.8%. Moving on to our payer mix. The preliminary payer mix for January consists of government-sponsored patient revenue made up 72% of total gross revenue. This is lower than budget by 1.1% and lower than the prior year by 5%. HMO was 3.4% of gross revenue, which was above budget by 2.6% and higher than prior year percentage of 2.5% of gross revenue. Our PPO was 21.6% of gross revenue, which was below budget of 22.3%, but higher than the prior year of 19.8% of gross revenue. Private pay was 3% of gross revenue, which was above budget of 2% and higher than the prior percentage of 0.7% of gross revenue. I do want to just mention in the month we had 3 high dollar private pay cases over 500,000, totaling over around $2 million in private pay for the month. Moving on to our productivity indicators, you can we'll see this how busy we are or were reflected in our productivity. Our productive FTEs were above budget by 64.3 or 5% at 1,342.7. Our non-productive FTEs were above budget by 51.1 or 30.6% at 217.9. I do want to say that we did have a number of staff that were out during the month of January in whether related to COVID or other family issues, and so that was really driving the non-productive FTEs above budget. Our total FTEs of 1,560.6 were above budget by 115.4 or 8%. Our productive FTEs per adjusted occupied bed of 4.66 was lower than the budget of 5.88 by 20.7% and lower than prior year of 5.39 by 13.5%. I know our productive FTEs per AOB is, looks good at 4.66, but really in terms of demonstrating how we were very much challenged in terms of staffing in many of the areas. And this is something that many of the hospitals in the area also encountered, but you can see that in these productive numbers. And then looking at total FTEs per adjusted occupied bed of 5.42 were lower than the budget of 6.65 by 18.5% and lower than the prior year of 6.09 by 11%. All right, looking at our other outpatient statistics, Whitmouth clinic visits were below budget in January by just 0.5% at 17,549, but were 7.2% visits above January of 2021. Looking at our DevCo outpatient visits of 1,828, they were below budget by 207 or 10.2%, for the month of January and 9% below January of 2021 visits. Washington Outpatient Rehab Center was below budget by 192. As mentioned, we did hire 2 physical therapists towards the end of end of December, and they've been ramping up. And we also had a new clinical director that started in January. So I think we'll start to see being able to have the Washington Outpatient Rehab Center get closer to budget. Washington Radiation Oncology treatments were down 25. However, this is higher than the prior year by 64 visits or 24.3%. Washington Outpatient Surgery Center was 15 above budget. It's driven primarily in gastro cases. And then Ohlone College Student Health Center, as discussed, continues to be below budget this month by 5, and the health center remains open, though most of the students are attending classes virtually. So we really Ohlone doesn't have many students on campus. Moving on to the key financial statistics and charity, days cash on hand for January ended at 159 days, a decrease of 4 days from last month, but an increase of 4 days from January of 2021. We did have a bond payment that was made in January of $4.3 million that accounted for 4 days. We also had lower AR collections in the month, and I will mention that we had some large staffing issues also in finance, as we've experienced throughout the entire healthcare system. Looking in February and March, we expect to receive $5.9 million or 5 days from the Hospital Quality Assurance Fee or HQAF program. We paid out an IGT of $1.8 million or 2 days in December. In February, we'll also pay out an IGT of up to $1.4 million or 1 day for the Quality Incentive Pool, the QUIP program, and expect to receive $5.4 million or 5 days, around 45 days from that IGT payment. Moving down to days of gross revenue and accounts receivable, they did come in above at 70. In January, the average daily revenue increased by 7.5% compared to the prior month. So you can see, given the higher volumes that we experienced in the month. But it should be noted that an increase in this average daily revenue results in an increase to days in AR. And there's a timing delay between higher volumes and the corresponding collections. So over the next few months, we should see those collections come in. Our patient cash collections of $38.8 million were down from the prior month by $4.9 million. We did have, as I mentioned, 30%, we did have some staffing challenges. 30% of our billing and collection staff were out. Now in February, we're back up to 95% of staffing. And we also, there were holidays that crossed over from December into January, and over the last 4 years, we've seen that also impact and increase from our days from 2 to 5 days. Although the collections were down from the prior month, they were higher than January of 2021 collections by $6.2 million or 21.6%. So we're watching our days in AR closely in terms of where they stand, and ensuring that we are continuing to do our patient cash collections. And then in charity care, there were $257,000 in charity care adjustments in the month of January. All right, that was the hospital operations for January. Are there any questions?
Yeah, Kimberly, this might be a rhetorical question. You mentioned several high dollar, presumably unreimbursed private pay cases.
Right.
My question is, does Kaiser incur this same challenge?
I want to say that they don't, because we have an emergency room that basically, as you know, is open for the community, and anybody can come to our emergency room that needs care, and we take anybody that comes, no matter what they can pay or what their insurance is. And so that is what makes us different than other systems such as a Kaiser. So, you know, that is something, and especially during the time that they, you know, patients need the care and they've been experiencing potentially delays in care, we're seeing some very sick patients.
That difference makes us who we are.
That is true. We are a community hospital here for our community.
Thank you.
I also had a question about what drives the outpatient observation days. It seems like that's an awfully high number.
Right. So that is something that we're continuing to work on, and we're looking at, and it's really the type of patient that comes into the emergency room and ensuring that they are placed in the appropriate level of care. So in terms of where when they are either placed in an inpatient status or an observation status. And so there are a couple of things that we're continuing to focus on, and this is some of the work that we're going to be doing with clinical intelligence and working on ensuring that we're making sure that the patients are placed in the right level of care. And we'll do that, and that starts at the very beginning from the emergency room. So that is something that we're continuing to look at. I don't know, Chris, or Larry.
Yeah, you know, it's a lot of these patients in the past may have been admitted and discharged in less than 24 hours. And when that happens, particularly with Medicare patients, they won't pay for it. So a lot of these patients were actually, by placing them in observation status, we're able to continue to charge for the work we do and collect on that versus having it denied by Medicare. You know, Larry and his team and the ED are working a lot on making sure that patients are placed appropriately and not admitted unnecessarily, which has been an issue in the past.
Right.
Yeah.
It's making sure they're in the appropriate level of care.
Yeah. And then some of the surgeries that used to be inpatient surgeries are now hospital outpatient surgeries. So there's a combination of surgical volume that's going into that outpatient observation status, or not inpatient status, I should say, because it's actually called hospital outpatient surgery status. And then the observation patients, we're really working hard to, number one, convert patients over to inpatient status when they meet the inpatient criteria quickly with the case management team, and as Kimberly mentioned, with the clinical intelligence group. And then we're trying to reduce the length of stay and work on the coordination of care, so getting diagnostics done quicker, getting consults done quicker for people that may need care but don't actually meet inpatient criteria to get into an inpatient hospital bed. So all those things are part of our plan with clinical intelligence to reduce observation length of stay and to identify and convert patients over that meet inpatient status earlier in the admission process.
And when Medicare denies those one-day stays, the reasoning is it's medically unnecessary. The admission was medically not necessary. So again, everybody's working together to get these patients placed properly.
Yeah.
Thank you.
Hopefully that answers your question. Yes. Any other questions? All right. Do you want me to go on to announcements?
That'd be great.
All right. I'm going to start with our Employee of the Month for February. It is Sang Kang, and he is our desktop support engineer and known to many of us throughout the healthcare system. When Sang Kang had the opportunity to convert his contract role at Washington Hospital to a full-time position, he happily accepted. With an extensive background in IT, Sang has been instrumental in several upgrade projects and troubleshooting computer issues throughout the healthcare system. He enjoys meeting different people and working in what he calls a dynamic environment. His manager, John Bell, notes Sang's strong work ethic and ability to work with different departments as the reason he is the go-to guy for desktop support. Sang was instrumental in our recent successful Joint Commission survey and magnet designation. Though before arriving at Washington Hospital, Sang had never heard of the patient-first ethic, it was consistent with his work ethic and personal credo, the customer is always right. In previous roles, Sang focused on making sure clients had the tools they needed to do their jobs. By helping those who provide direct patient care, Sang feels his work is part of the patient-first ethic. It's a chain reaction, he says. As a Fremont resident, Sang and his wife raised 2 children, and now, when not at the hospital, he typically has a tennis racket in hand. For several years, he has played in local tennis leagues, often acting as team captain. Congratulations for Employee of the Month, Sang Kang. Yes. All right, and then just a couple of other quick announcements. I do just want to continue to announce that Washington Township Medical Foundation continues to operate our community vaccination clinic. As of Friday, February 4th, a total of 85,288 COVID vaccine doses have been administered to community members at our vaccination clinic. As of Friday, February 4th, a total of 3,143 vaccinations have been administered to the age group of 5 to 11-year-olds. And if you remember, that's at this point, that's also another age group that is eligible to receive their vaccinations. On Tuesday, February 8th at 6:30 p.m., Dr. Rohit Sehgal, cardiologist with Washington Township Medical Foundation, presented heart attack symptoms and prevention, all on Facebook Live and YouTube. 160 community members participated in the live event, and since that time, 267 additional people accessed the presentation. A couple of upcoming events. Thursday, February 17th at 6:30 p.m., Dr. Bryant Bonner, orthopedic surgeon, will present advances in joint replacement surgery. On Wednesday, February 23rd at 3:30 p.m., Dr. Stephen Catalia, infectious disease specialist, will present COVID-19, what families need to know. And then on Wednesday, March 2nd at 6:30 p.m., Sari Gent, yoga instructor, will present Improve Your Balance with Yoga. And these are all on Facebook Live and YouTube. I do also just want to mention at the annual meeting of our charitable foundation on January 25th, 2022, our trustees voted to disperse a total of $758,537 to the hospitals to support various programs and equipment. This distribution included $150,000 for COVID-19 reagent costs and support for nurse trainings, supplies for new families in need, and funds to support free community mammography screenings. And since 1987, thanks to their generosity and commitment to our community, the foundation has dispersed more than $22.6 million to the hospital. So it's wonderful, and we thank them for all of their support. And those are my announcements for this evening.
Wonderful, thank you. Wonderful gifts by the foundation. We will now go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. And as we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She'll be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable action taken. Thank you. The board will now adjourn to a closed session.